Have you ever stopped to think about what really makes a hospital high quality? I mean, beyond the amazing doctors and shiny equipment, we usually picture hospitals just as places for healing, which of course they are, but they're also these incredibly complex systems, and they face huge operational challenges. One of the biggest, and maybe most serious, is something called healthcare associated infections, or HAIs. These aren't trivial. They're a common, really serious problem affecting recovery, keeping people in hospital longer, and, straining resources. So today's deep dive is pretty exciting. We're looking at a study from the University Hospital Federico II in Naples, Italy. And what's fascinating here is how they tackle HAIs. They used a method usually found in manufacturing, Lean Six Sigma.
That's right. And it's not just an academic curiosity. HAIs are a huge global priority. They're not just a medical issue. They're seen as a really critical indicator of overall healthcare quality. This study, it lays out a really practical, data-driven way to make a difference, not just clinically, but economically too.
Okay, so our mission today. Let's unpack how this Lean Six Sigma approach helped cut infections, reduced hospital stays, and basically give you a shortcut to understanding this whole idea for patient safety. All right, let's get into it. We focus so much on the surgery itself, right? The main event. But what happens afterwards, that recovery phase, can be just as critical, especially with infections. HAIs are a major worry. What makes them such a persistent problem? Why is this something every hospital needs to prioritize?
Well, the scale is just immense. If you think about it, in Italy, healthcare is, what, over 7% of the GDP? And eats up like 80% of regional budgets. It's massive. And within that huge system, HAIs aren't just a danger to patients' health, sometimes their lives, but they're also a huge economic burden. You've got factors like populations getting older, which means more complex cases, longer stays. And then there's the human factor, the chance for errors, inconsistencies in care. It all adds up. And surgical site infections, specifically, they're one of the things looked at most closely as a sign of how good, how safe the cure really is. It's a key indicator.
So it's really not just about fixing the immediate problem someone came in with. It's about stopping new problems before they start and making the whole system work better, more proactive.
Exactly. Proactive safety, not just reactive treatment.
Okay, and this is where it gets really interesting. The study didn't just look for medical solutions. They brought in this Lean Six Sigma method from manufacturing. For listeners who maybe haven't come across LSS before, it might sound a bit industrial. Can you give us a quick rundown? What is it and why use it in a hospital?
Sure. LSS, fundamentally, it's a powerful problem-solving toolkit. Came largely out of Japanese manufacturing. It kind of merges two ideas. Lean is all about cutting out waste, making things efficient, smoother flow. And Six Sigma is focused on reducing errors, defects, using statistics, data to make things consistently high quality. So in healthcare, you translate that. It means finding out why a process isn't working perfectly, eliminating those causes, and improving how it performs. And it works. We've seen it used successfully to, say, speed up critical patient transfers or make operating rooms run more efficiently, even things like cutting down patient waiting times. It's about predictable, high-quality results every time.
Right, it sounds very structured, like a way to methodically find the weak points and fix them properly. So in this Naples study, what was their main goal using LSS for these HAIs?
Their aim was very, very clear. They wanted to analyze every factor, everything that could possibly lead to what they called sentinel bacteria colonization in patients. Think of these sentinel bacteria as warning signs, specific bugs that signal a higher infection risk. So identify all the potential causes and then, crucially, put concrete actions in place to improve the whole care process and cut down that risk and cut down those long hospital stays too.
And they followed that classic Lean Six Sigma roadmap, didn't they? The DMAI cycle. Define, measure, analyze, improve, control. Let's walk through how they did each step.
Exactly. So phase one, define. This is where you nail down the problem. They put together a multidisciplinary team, doctors, engineers working together. That's key. They clearly defined the main issue, the dependent variable, as that sentinel bacteria colonization, basically, any patient testing positive. And they identified potential influencing factors, the independent variables, things like how many procedures a patient had, that diagnosis group, or DRG, which tells you about case complexity, total time in hospital before surgery, and patient age, all potential risk factors. And the big goal, reduce the number of infected patients and, just as importantly, reduce their length of stay.
Okay, defined. Then phase two, measure. How did they actually get the numbers to see where things stood before they changed anything?
Well, this was a huge undertaking. They meticulously collected data. We're talking over 20,000 patients undergoing surgery between 2011 and 2014. They pulled all this from the hospital's own information system, QOYNI. In that initial period, before they made changes, call it the before picture, Jan 2011 to the Dwyer 2012, they had about 11,500 patients. And of those, 0.37%, 43 patients tested positive for these sentinel bacteria. They also saw huge variation in how long people stayed in hospital, whether they were colonized or not. Colonized patients averaged 45 days. That variability is a big red flag in LSS terms.
25 days average. Wow. Okay, so they defined the problem, got the baseline data. Now for the detective work. Phase 3, analyze. Finding the why. What did they find were the root causes?
Right, this is where you dig into that data. They found one specific bacterium, Pseudomonas aeruginosa was the most common culprit. And crucially, the statistics showed a definite link, a positive correlation between the number of patients colonized and the number of procedures they had.
So more procedures seem to equal higher risk somehow?
Potentially, yes. Or something about the processes around those procedures. So to break it down further, they used an Ishikawa diagram, a fishbone diagram.
Oh yeah, the cause and effect diagram.
Exactly. It helps map out potential causes. They grouped them into four main areas. Materials. Things like maybe the wrong antibiotic prophylaxis or contaminated instruments. Processes. Issues in pre-op, during surgery, post-op protocols, how wounds were managed, healthcare staff, maybe gaps in training or less than perfect hand hygiene, and management. Things like not having solid screening protocols or lacking standard strategies across the board. And importantly, they didn't just guess these causes, they checked them by surveying the actual healthcare staff, getting that frontline perspective.
Makes sense. So once they had those likely causes pinned down, they moved to phase 4, improve. What changes did they actually make? What were the fixes?
Okay, so based on all that analysis and expert input, they rolled out a whole set of targeted actions across those four areas. They reviewed and changed the antibiotic protocols around surgery, making sure they were absolutely optimal. They brought in stricter sterilization rules for instruments, gowns, everything, much tighter control. They also improved data collection with a new computer surveillance system for, better real-time tracking, developed new standard ways to manage wounds both during and after operations, promoted standard procedures generally, ran immunization campaigns for staff, and a really big piece was boosting training and information for everyone involved, making sure the new, safer ways were understood and followed.
So lots of changes. Then comes the final phase, phase 5, control. How do they make sure these improvements actually lasted? How do they monitor it?
They kept tracking things closely for 2 years after the changes, from January 2013 to December 2014. They watched key indicators, like those hospitalization days, and how well diagnostic and treatment procedures were being selected. And the results, they were really quite compelling. That colonization rate, it dropped from 0.37% down to 0.21%.
Yeah, nearly cut in half.
Pretty much.
Okay.
And maybe even more significantly, for those patients who did still get colonized, their average hospital stay dropped massively. Remember, it was 45 days average before, it went down to 36 days average. That's a 20% reduction. And the variability, the standard deviation, also dropped significantly, showing more consistency.
A 20% shorter stay, even if you did get an infection. That's huge for the patient, and I imagine for the hospital, too. So what's the big takeaway here? It sounds like a clear win-win.
Oh, absolutely. The benefits really ripple outwards. For patients, obviously, shorter stays, less risk, better experience, higher satisfaction, a safer, quicker return home. For the hospitals, it means direct cost savings, shorter stays cost less, treating fewer infections costs less. And it's a measurable jump in the quality of care they provide. What this study really demonstrates is that even in a super complex environment like a hospital, where maybe clinical care isn't always perfectly standardized, applying these kinds of disciplined process improvement methods, allocating resources better, cutting waste, it's absolutely essential and possible.
Yeah, it reframes it. It's not just about infection control and isolation. It's about fundamentally rethinking how healthcare processes are managed and improved.
Precisely. This kind of LSS approach, maybe combined with ongoing surveillance, continuous training, it's a template. It could be used to redesign and improve all sorts of healthcare processes. It really offers a solid foundation for quality improvement across the whole sector.
So our deep dive today really highlights how this systematic, data-driven thinking, Lean Six Sigma can make a massive difference in something as vital and complicated as healthcare. They defined the problem, measured it, dug into the causes, put fixes in place, and made sure they stuck. And the results from Naples speak for themselves. I mean, think about it. A 20% cut in hospital stays for infected patients, nearly halving the infection rate overall. That's not just tweaking, that's transforming a system. It really makes you think, doesn't it? If applying these kinds of rigorous, almost engineering-like principles can achieve this in healthcare, What other complex areas, maybe even in our own daily lives or bigger societal systems that seem messy or unpredictable, could be dramatically improved if we took a similar methodical, data-focused look? Where else could we find those invisible risks and fix them? We hope you found this deep dive valuable. Until next time, keep digging for those nuggets of knowledge.